All right, so we'll just briefly have an overview of the thyroid anatomy. We had not discussed this in other lectures, but I thought maybe it would be a brief review could be helpful. Just remember that the thyroid gland is much lower than most people think it is. You can review any number of physical exam videos on YouTube if you need a refresher. There's an anterior approach. I personally prefer the posterior approach. I feel like there's more neck coverage from behind, and also by palpating and visualizing maybe some of those anatomical abnormalities might be less likely to throw you off. So again, the thyroid gland, it is located between the cricoid cartilage and the tracheal rings. You can find the even on a large person, you can just identify the suprasternal notch and place your fingers just above that. It's always helpful to have your patient swallow a sip of water as you palpate, so you can feel the upward movement of the thyroid gland. Again, we're looking for nodules today. So most of the time, thyroid nodules are found by the patient. They could be found by the clinician, and it is fairly common to have them found as an incidental radiographic finding when the patient has had other imaging done. They're very common. You're going to find these in about 4 to 7% of U.S. adults. Once again, females are more likely to have these pop up, but 90% of these are benign. It's the remainder of them can be a primary malignancy or metastatic. That is a lot less likely. And the clinical importance here of identifying a thyroid nodule and working it up is really to rule out cancer. So that's our main focus. These are mostly benign, and your history and your physical will lead you to those clinically important risk factors. You're going to have a higher prevalence of these things being malignant in children or patients that had a previous history of head and neck or even chest irradiation. Family history is present, young adults, unfortunately. So again, usual approach on history and physical. This time we have a very low accuracy based on history and physical alone for predicting the chance that these things are cancers, and that is why there's a proper approach to these, the diagnosis, and to make sure that these things are indeed not malignant. So definitely need to recognize those history and physical exam findings or features that cause an increased risk. I'm going to be focusing on the American Thyroid Association, ATA, and the National Comprehensive Cancer Guideline recommendations here. There are many different other colleges out there with different recommendations. This is evidence-based. It's widely utilized. You might find some nuances with recommendations in terms of when to size and biopsy. Those can come up, but when you're seeing a patient with this, referring to evidence-based guidelines, you don't have to remember every single step, but just use your evidence-based, use up-to-date, use 5-minute consult, something that's evidence-based, okay? So all patients, history and physical, you're going to palpate that thyroid just above the clavicular notch, and every patient with a thyroid nodule is going to have a TSH. Not a T4, not a CBC. You're going to be doing your full history and physical, but for the sole purposes of a nodule, TSH. Then based on that and based on your exam findings, you're going to confirm the presence of the nodule and define it with an ultrasound, okay? So all people full physical, TSH, then ultrasound. If they qualify, they might need a biopsy or a fine needle aspiration, if indicated, to rule out cancer or look for atypia or high-risk features. And again, I'm using the ATA guidelines. So all those red flags during our history, do pay attention to those historical and physical finding features, some of which, anything that pops up and is rapidly growing, always pay attention to that. Same goes for dermatology findings when you're suspicious of malignancy. We said this at the beginning, history of childhood, head, neck, or chest, XRT, family history of thyroid cancer, young adult males, and hoarseness on exam. Physical exam findings, fixed hard mass, they're talking, you notice they're hoarse. That could present with an obstructive symptom, vocal cord paralysis, maybe they can't talk entirely. And of course, cervical lymphadenopathy, particularly if it's not painful, would be suggestive of malignancy. Sometimes you may not palpate the nodule directly. This was incidentally found on a CT scan. These things can be retrosternal. They can, large multi-nodular goiters, could cause dyspnea, so they may come in out of breath. They can be dangerous when there's tracheal compression involved. Large substernal goiters can cause superior vena cava syndrome. Remember, that's the jugular vein distension and facial erythema. It gets worse when you bring both their arms above their head. That's the Pemberson sign. That might have been on your boards recently. So as far as diagnostic workup goes, again, TSH on all patients. Most of your patients will be euthyroid. You're doing a good history and physical. They're coming in just because they have a nodule. They don't have any symptoms. Most likely, if they don't have symptoms, it's unlikely that they will have a thyroid dysfunction associated with that. However, TSH is an independent risk factor. So you can have a hot or a cold nodule. Cold nodules are always suspicious for being cancerous, and a hot nodule, which is kind of counterintuitive, as I would think that cancer proliferates quickly and should be hot. No, cancer is rarely productive. Okay, just keep that in mind. If you get confused, if you see that on a test or something. So if your patient, you're sending a TSH, you have a low TSH, with those patients you want to obtain scintigraphy, so the radioactive iodine test, because they can identify a hyperfunctioning nodule. It's sending off a lot of T4, so you're hypothyroid, right? TSH is low. So RAI uptake and scanning is helpful to identify a hyperfunctioning nodule. Your history is also probably going to lead you towards wanting to look for this if they are having tachycardia or weight loss, maybe some subtle symptoms if you dig in there that the patient didn't think to tell you. So just keep that in the back of your mind. Any normal or high TSH, go ahead and proceed with ultrasound, but low TSHs, you're going to get an ultrasound as well, but you are also going to obtain RAI to make sure they don't have a hyperfunctioning nodule in there. As far as imaging, ultrasound is it, okay? Thyroid ultrasound, it's used to answer questions about the size and anatomy of the thyroid gland and the adjacent structures. It can also identify those posteriorly located nodules that are predominantly cystic. It can also identify surrounding structures and tease out if they're actually nodules, right? In TSH-induced hyperplasia of the follicular tissue, maybe wasn't a nodule, it was just hyperplasia of the tissue. This can be found in Hashimoto's. It can find thyroid tumors. It also helps to distinguish blood flow and, again, adjacent structures, so it'll identify abnormal lymph nodes and things of that nature. The whole goal of the ultrasound is to identify the size and anatomy of the thyroid gland and all of its adjacent structures. So I'm saying that again because it's very important. The thyroid nodules are also classified for malignancy risk according to their appearance on ultrasound. This is your diagnostic workup. No fancy CAT scans. The ultrasound is actually superior. So it's also going to pick out if you have a multinodular goiter. This is going to pick out your 4 larger or largest nodules for your next step, which is a fine needle aspiration. It might also reveal that this is purely a cystic lesion. It is a cyst. It has no echogenicity, and so you do not need to send these for biopsy or FNA. Again, this is to classify your malignancy risk, define the nodules as cystic, find features that are concerning for malignancy. These are not used for cancer diagnosis, so you cannot make a cancer diagnosis based on the ultrasound alone. I will also note that this is not to be used as a screening tool. It's not recommended that we just routinely screen people by doing thyroid ultrasounds. Here's another one of those very busy slides I love to throw at you. This is from Up to Date. It has, it's just an example of sonographic patterns. I'm talking about features here that can estimate risk of malignancy. You can see that this is actually very straightforward. Size does not necessarily matter. You can see at the lower end of the spectrum, very large cystic nodules without anything above it, unlikely to be malignant. Purely cystic nodules are absolutely benign. They do not need a biopsy. But you'll see. You don't memorize this. This is easily searchable. And just remember, with ultrasound, when we say we're dealing with ultrasound waves, right? So the descriptive terms, echogenicity. It's the way the ultrasound wave is reflected back to the transducer. So each tissue type has a particular echogenicity that's normal for that organ. And so in disease states, the echogenicity can be altered, and the radiologist will usually define these as either more echogenic or hyperechoic, which is brighter. That's the white on your screen, or as less echogenic, so hypoechoic, that is going to be darker or gray on the screen. It helps the radiologist to categorize the type of disease process involved. You might also hear anechoic, and that is just pure black on the screen. Example would be bone. The transducer, those waves cannot penetrate bone, and so you end up actually with a shadow. So everything you wanted to know more on ultrasound. Okay, so we've gotten our ultrasound. We have obtained our TSH. We have defined this nodule. Yes, it's present. Here are the features. You have the reading back from the radiologist, and the next step may or may not be a fine needle aspiration. So what are the indications? I just give you a lot of information. Just remember, solid hypoechoic is bad, okay? So if it's greater than a centimeter, it's solid. it's hypoechoic, so it's dark, it's less echogenic than normal. It's bad. So other things, this is true for many other types of cancers, breast cancer specifically. If you have irregular margins, microcalcifications are bad. If it's abnormal, if this cyst is round, right? Well, if this is taller than it is wide or has calcifications, if it's has extrusion of soft tissue, so it has displacement of soft tissue, all those things are bad. Regardless of the size, so size does not matter. Again, I will say size does not matter. Abnormalities matter. So if it is a subcapsular in nature near the laryngeal nerve, if it is, if it starts to, the borders are outside of the actual thyroid tissue, if you see rim calcifications and it has tissue extrusion through those calcifications, and sonographically abnormal cervical lymph nodes. Again, most of the time those are not going to be painful if they're not associated with infection, right? So the procedures is a fine needle aspiration. This is really the best method to assess for malignancy. This is your gold standard for assessing for malignancy. This is a beautiful procedure. It's easily done with ultrasound. It's safer with ultrasound. Always use ultrasound. You may be referring the patient at this point. You do not need to hold aspirin or anticoagulation because this is a teeny little needle with multiple passes. The FNA cytology is reported in general using the Bethesda system for reporting thyroid cytopathology, so the Bethesda system. And again, purely cystic nodules do not require biopsy. I said this earlier, but what do you do if they have more than one nodule, like a multi-nodular goiter? It's going to take the 4 largest nodules, a centimeter or larger in diameter, and those are going to be the ones identified for biopsy. I will note that you should be doing this under ultrasound, particularly when you have a posterior located nodule, because you can miss it. If you do it just by palpation, you could get the tissue next to it. Let's see. Oh yes. So this is again this is the Bethesda system for reporting. However, FNA guidelines may differ between colleges. Like the American College of Radiology, they use TRADS system, so they might have some different thresholds, and they're a little more complex than the ATA criteria. So I just wanted to point that out. If you end up going into endocrine field, you'll become more familiar with this. But there's no need to be memorizing all this, okay? As far as diagnosis goes, you've made your diagnosis, you've palpated, it's a nodule, you've done your TSH, you've done your ultrasound, and then an FNA if needed. Well, what do I do with these people that have benign nodules? It's purely cystic, or maybe it wasn't purely cystic, but it didn't really meet criteria for FNA. The patient didn't want one, and they had a really low chance of this being malignant. We had a discussion. Well, you need to follow them up. Make sure you educate your patient, stressing, even though this might not look benign now, the importance of follow-up. So, and follow-up does not need to be a repeat TSH. This is just ultrasound, a physical exam and ultrasound. You should do it at 6 to 12 months if it is sub-centimeter and it had some suspicious characteristics but didn't meet the criteria for FNA. You should be following up yearly to 24 months if they have an indeterminate suspicion on ultrasound, and every 2 to 3 years for very low-risk nodules. So as we follow up, again, some pearls here are that single or multiple thyroid nodules are commonly palpated by the patient, by the clinician, or accidentally discovered on imaging. It won't be uncommon to have a patient follow up from the ER after they had gone and had a trauma workup or a scan for one reason or another, or C-spine for arthritis, whatnot, and they're referred back to their PCP for incidental findings. Thyroid function tests should be done in all of these patients, a TSH, to look for evidence of subclinical hyper or hypothyroidism. Recall in our thyroiditis lecture that if they have a history of Hashimoto's, that will be a red flag. If they have a nodule that pops up, they have about an 8% risk of malignancy, so do follow those patients closely. Maybe specifically ask about a history of Hashimoto's thyroiditis in their history. They may have forgotten about it. The FNA cytology for thyroid nodules meeting criteria can be looked up easily. Like I said, that chart I gave you on up-to-date, you can also find a 5-minute consult very easily to look up. Ultrasound guidance is going to improve your FNA diagnosis for both palpable and non-palpable nodules. You know that you're going to be in the center of that nodule. So I recommend always using ultrasound. It's easy, it's cheap, and it's widely available, right? And it makes it safer. Remember that there's a lot of vessels in that area of the neck, and you don't want to go poking around blindly, okay? And then clinical follow-up is required even if it's benign. So I have here, this is from 5-minute consult. I just wanted to give an example of an algorithm when you feel a little bit overwhelmed or you just need a quick and dirty reminder of the steps to take. You can pull this up on your phone. You can breeze through this before your patient appointment. It's very simple, straightforward. This goes into a little bit more detailed after the FNAs. And this is from up to date, so this is a nice, very straightforward summary that I just took 22 minutes and 30 seconds to talk about. So I hope you all have a great day, and feel free to get a hold of me if you have any questions.